So I'll start with the concept of why mass separation is needed in blood purification. I think the first speaker already covered in several parts my topic, so I think I will have an easier way to show you. But basically, when we have retention molecules due to kidney failure or other organ failure, we have accumulation in blood of specific molecules that are small, middle, or large. And for this reason, we need blood purification. This is a typical uremia retention molecule profile done by proteomic assessment, where you see several different peaks of substances that indeed correspond to retention molecules that are normally affecting several different organs, at the end causing high mortality and poor quality of life. In the acute patient, we know that insults may lead to accumulation of pathogen and danger-associated molecular patterns that activates a protein system, vascular and tissue cells, blood and lymphatic cells, with a cascade of events leading to activation of coagulation, of presence of complement activation, presence of cytokines, chemokines, etc., that in turn may affect different organ function. What are the mechanisms that we using? We have seen before, basically, we use separation by a membrane or separation by a solid agent, and here are the mechanisms. In dialysis, we mostly use diffusion, and indeed, you see that for small molecules, this is an excellent method of removal. If you increase blood flow, you can get very high clearance. But unfortunately, the diffusion coefficient for molecules tend to decrease significantly as the solute molecular weight increase. And for this reason, you need convection, which has been mostly utilized in hemofiltration or hemodiafiltration, where you see that convection depends very much on the sieving coefficient of the membrane. And we have here specific curves that are identifying the characteristical permeability of different membranes, which are far from the classic performance of the glomerular basement membrane. It is not only the molecular weight, but also the molecular radius that affect the capacity to be transported across dialysis membranes. So in spite, we have designed different membranes, and the most recent are called high retention onset or medium cutoff membrane, where still we have an improved sieving profile. We have left out several different molecular weight solutes that cannot be removed by classic membranes. And indeed, these solutes, which are between, let's say, 20 and 50,000 Daltons, seems to have a specific clinical effect of intoxication, inflammation, anemia, and cardiovascular toxicity. So these molecules are very important, and probably the optimal possibility to remove them is by adsorption. And we have new devices that allow to utilize specific characteristics of polymers that are designed according to industrial chemistry to provide specific adsorption isotherms that describe the amount of substance that can be absorbed by a gram of sorbent. We also used to study the mass transfer zone, and I will show you our experiments to test the quality of the cartridges that are developed. Hemoperfusion seems to overcome the limitation of dialysis membrane with potential selectivity of removal. You can place the sorbent in contact with blood without altering coagulation and problems of circuit pressure. But of course, we have specific requirements. We need to demonstrate effectiveness, hemocompatibility, mechanical strength, no fouling or clotting activation, and to have a well-designed cartridge. In the very early experience, we did hemoperfusion with charcoal as a sorbent, and there were several different side effects induced by the poor biocompatibility of the sorbent. So you see that chills, fever, cutaneous rash, and thrombocytopenia are quite common in this case. Today, we know that the characteristics of a suitable adsorbent material should be high selectivity to enable sharp separation, high capacity to minimize the amount of sorbent needed, a favorable kinetics of transport, chemical, thermal, mechanical strength and stability, free-flowing tendency of the fluid phase, which is blood in this case, high resistance to falling, and no tendency to promote undesirable effect. In the future, also will be interesting to see if we can regenerate these cells. We have different sorbent materials, natural, like zeolites and lumosilicates, or porous carbon of cellulose-derived origin, or synthetic, almost different polymers can be cross-linked with divinyl benzene, providing a very high surface-to-volume ratio. Just think 1,000 square meter per gram of substance, enormous amount of surface. Mechanisms can be direct adsorption, anion or cation exchange, and immunoadsorption, and they may come in fibers, granules, beads, spheres, pellets, flakes, powder. They are mostly divided into macro, meso, and microporous, depending on the pore size. So how do we measure the efficiency? We use the isotherms, which is basically a curve that can be experimentally achieved based to the point of equilibrium that is reached at the given amount of adsorbed substance. This is an example of what we have done to create an adsorption isotherm for vancomycin, for example. And you see enormous amount of vancomycin can be absorbed with significant mass reduction, and the structure of the curve is very similar to the theoretical isotherm. If you look at the characteristical structure of uncoated charcoal, there is no wonder we have some side effects, because the surface is extremely rough and poorly biocompatible. But recently, there was a development of a series of resins that were particularly smooth and coated, and the neutral macroporous resin that are available today are extremely smooth and easy to be circulated in specific cartridges. Here is a study that we have done in our institute, where you see progressive magnification demonstrates the smoothness at the external part and internal part, and the characteristics of the porous with high surface area develop inside the pores. Thanks to nano-sieve, molecular sieve control technology, manufacturers today can adjust pore size distribution according to target toxin. And here you see a 3D reconstruction of a typical pore bead that is provided in order to absorb specific toxin. We have different forces, including van der Waals forces, ionic bonds, hydrophobic bonds. These last one are the most stronger type of bonds. And this type of adsorption dynamics is facilitated by an extremely simple and smooth circulation of blood between the beads. Interparticle, extraparticle, and even intraparticle distribution of the fluid phase is guaranteed, and according to specific laws, we have different variables that may affect distribution, including particle diameter, packing density, interparticle porosity, path tortuosity, length and diameter of the cartridge. we wanted to study the flow distribution inside the cartridge to ensure that the quality of the product is adequate. And we did a CT scan, and here you see the progression of the flow distribution inside the cartridge, which is extremely homogeneous, showing that all the surface is utilized for adsorption. And this was done for different cartridges with different priming volumes. Again, maximum homogeneity of the distribution of flow. And this ensures, of course, a smooth carrying over of a session during dialysis with the stable pressure drop inside the cartridge. As I mentioned before, we studied also solute concentration distance profile called mass transfer zone. It is the distance between maximum utilization and zero utilization of the sorbent inside the cartridge. The shorter is the mass transfer zone, the better is the design of the cartridge. So this will be the ideal, and this is a optimal design of the cartridge, while these are representing non-optimal design. So we did the study. We specifically utilized the experimental setup in our institution with the system to provide simultaneous withdrawing of blood components from the circulation. And you see, thanks to this machine that we have developed in our institute called Galileo, we have tested the mass transfer zone. And it is interesting to see that practically the mass transfer zone is shorter than 1/3 of the length of the cartridge, showing a very good design of the cartridge. Another important aspect is biocompatibility, and we did study this with two methods. One was a static test with incubation of monocytes with the sorbent and with the medium control. And the other is the dynamic test where we circulated in vitro for 120 minutes the cells. And in practice, we did not find any difference between the exposure of the cells to the sorbent and the exposure to the cells of the control medium. In particular, you see practically not at all a significant difference in static and dynamic tests. We studied cell viability, apoptosis, and necrosis. So this is the evolution of CRRT over the last 40 years. We had discussed yesterday evening with some colleagues the evolution from the Diapact machine to the Prisma machine, especially to enable the ICU nurses and ICU doctors to do an easy priming. And you see that now we have moved through a series of new generation of CRRT machines. But I think that, in fact, the adsorption represented the real new frontier of CRRT. And in fact, we have the possibility to have available different type of sorbents and cartridges for different purposes, from chronic patient to acute patient to intoxicated patient to liver failure patients, depending on the structure of the sorbent. We can do hemoperfusion directly with the isolated circuit or in combination with CRRT. Now, there is an important experience on a wide number of patients carried out using hemoperfusion and adsorption in combination with hemodialysis for patients with specific symptoms, including pruritus, osteodystrophy, sleep disorders, restless leg syndrome, and accelerated atherosclerosis. All these syndromes seem to be correlated with retention of specific solutes. So the combination is easy. There is a cartridge that is called 130 HA130, and it has been studied in a very large population This is more than 1,400 patients in which the hemoperfusion plus hemodialysis group was controlled with the standard hemodialysis group. And indeed, the carried out study was for 24 months, showing the significant reduction in retention molecules such as beta-2 microglobulin and PTH, but also reduction in inflammation, reduction in cardiovascular event and all-cause mortality, and especially improvement in quality of life. I think one of the issues was to consider whether to use high or low flux membranes, and this study on more than 440 patients demonstrated that independently on the use of low or high flux dialyzers, there is a survival benefit and improvement in retention molecules and quality of life and symptoms when you associate hemoperfusion with either low or high flux dialysis, showing that the importance of adsorption in this case seems to be quintessential to remove those specific molecules. What is the recommended regime? Well, probably it is once per week because of the very slow equilibration of the solutes from the interstitial space to the intravascular space. So it has been utilized with different machines. And recently there was a systematic review and meta-analysis that we carried out trying to see if there was a significant advantage in terms of several aspects. And studies included at the end approximately analysis on 12 papers that characterized the advantage of HP plus HD compared to classic hemodialysis. Here you see that there was a significant difference in case of studies with different study design, both randomized trials and cohort studies at 1 year. And this is also related to different age subgroups at 1 year. But the interesting thing is that we have data at 2 years for different studies, randomized and cohort studies, and also for different age groups. Of course, in particular, there seems to be a significant advantage in the group over 60 in terms of symptomatic aspects. So concluding this analysis, we were able to basically say that HP plus HD removes the uremia retention products in a much more efficient way. There was a reduction in microinflammation and renal anemia. There was improvement in left ventricular function, and cardiovascular events were reduced. And finally, the quality of life seems to be very importantly affected. So these are the number of indications that have been proposed based on these different studies that go from inflammation, uremia retention products, malnutrition, pruritus, etc. And the benefit that have been documented is an improvement in appetite, muscular strength, cognitive function, pain relief, sleep, blood pressure control, and quality of life. This led me to write this editorial in Blood Purification, where I mentioned that this may require further studies, but still represent one of the most interesting options in current dialysis research and practice because of the important effects documented in these studies. Adsorption has been traditionally utilized for intoxication, and you see, for example, drug overdose, biotoxin, pesticides, rodenticides, industrial toxin. We have demonstrated a very important reduction in concentration with improvement of therapeutic effect using this cartridge called HA230, which has a specific sorbent technology to remove substances, for example, like the organophosphorus toxins This is a study in 68 patients where the combination of hemoperfusion plus hemodialysis was definitely superior compared to classic hemodialysis. Another thing was in patients with organophosphate poisoning, the observation was that more frequent sessions are more effective than one single prolonged session. And this is very important for a series of endpoints that have been provided. Again, this is another case of a study for paraquat poisoning, where the clearance was much higher in case of short repeated sessions compared to one long extended session. And that led also to the possibility to consider that cytokines can be a target for removal, such as other inflammatory mediators in sepsis, burns, trauma, cardiac surgery, ARDS, pancreatitis. Now, I want to show you our idea of the possible sequential integrated approach to sepsis, based on the fact that we move from infection to immunodysregulation to organ damage. At the beginning, we have the pathogen, then we have endotoxin, then we have cytokines, and then we have organ failure. So our idea is that there is a therapeutic window for every of these specific targets. And if this is the case, we have adsorption today available for every different type of target. For example, there is a filter today capable of removing viral particles or even removing bacteria. Then we have filters that can remove endotoxin. And this has been demonstrated with the polymyxin B polystyrenic fibers combined in a cartridge to remove in vitro and in vivo large amount of endotoxin. Several years ago, we published these changes in SOFA score at 72 hours in patients with abdominal septic shock. And we found also 28-day survival difference, although our study was not designed for a change in survival. More recently, while the Euphrates trial failed to meet the primary endpoint in the United States, they analyzed per protocol modified population, and the population with endotoxin activity assay between 0.6 and 0.9 seemed to have a significant benefit from the extracorporeal removal of endotoxin, with a signal of almost 6% improvement in survival, improvement in hemodynamics, and improvement in mechanical ventilation free days. But when you cannot remove the bacteria, you cannot remove the endotoxin, or at least not completely, you end up with a kind of immunodysregulation in sepsis, so with significant peaks of different substances that can be pro-inflammatory and also anti-inflammatory. We are talking about an immunodysregulation. And this is where you need immunological support. So the cytokine release syndrome is a systemic inflammatory response triggered by infections, drugs, antibody-based therapies, etc., with rapid release of cytokines into the blood from massive T cell stimulation. And this stimulation ends up spilling over cytokines into the overall circulation, leading to several different organ dysfunction. The concept is that sepsis, hemophagocytic lymphohistiocytosis, viruses, CAR T cell therapy, so they can activate a series of immunological responses that start with innate immunity leading to hyperinflammation. And some patients die with intractable hyperinflammation. But subsequently, the adaptive immunity may also be activated, and some patients die due to immunoparalysis. And in fact, we have anti-inflammatory mediators that overcome the action of the pro-inflammatory mediators. This is due to a damage to endothelium and organ failure. Now, studying different sorbents already 25 years ago now, we found that there was a capacity to remove beta-2 microglobulin. But very soon we discovered that they were able to remove also significant amount of cytokines. This leading to a blockade of the activation of the nuclear factor kappa B and the cascade at the cellular level. So today, cytokine adsorption is indicated in critical condition where the typical cytokine release syndrome is indeed activated. And being biocompatible, you can put this sorbent in contact with blood, absorbing cytokines and solutes in the range up to 60 kilodalton. Our hypothesis put forward many years ago was called the peak concentration hypothesis. The concentration hypothesis shows that extracorporeal blood purification may cut the concentration of the highest solute in blood, either pro or anti-inflammatory mediators, or even in a simultaneous activation of the two system, leading to some type of immunohomeostasis. What is the typical clinical response that we see when we applied a sorbent into a patient with the cytokine release syndrome? Decrease in the circulating cytokines, improvement in hemodynamics, improvement in SOFA score. That's a very interesting approach with minimal or no side effects. And in fact, you see, for example, in a typical critical ill patient, the significant decrease of the vasotropic inotropic score with the parallel improvement of the quality of pulmonary exchanges, but significant improvement in hemodynamics. So the idea of the peak concentration hypothesis is that combining hemoperfusion with CRRT, you can achieve some type of endothelial protection. This is why we recommend the use early, because it makes no sense to treat the patient when you have already developed organ damage. And that's why I think this therapy should be indicated in patients where an impending cytokine release syndrome is present. In several studies, we have seen changes in interleukins and pro-inflammatory mediators and SOFA score. We have seen completely lowering different pro-inflammatory mediators and also improving 28-day survival. We also have seen that the isotherm for these substances seems to saturate the sites of the sorbent after 4 to 8 hours. So 6 hours probably is the maximum you should use this therapy. Makes no sense to use it for 24 hours. But the important aspect is, what then is the prescription that we suggest? Well, I can transfer to you our idea, recommendation, and experience, where we basically do, in the first 24 hours, we do 2 sessions of approximately 4 to 6 hours. And then on day 2 and day 3, we repeat 1 session, depending also on the hemodynamic response of the patient. And here, maybe later we can discuss about what are the parameters that we use to prescribe the different therapies. Again, using isolated or in combination with CRRT, no difference. Last year, we, before the Vicenza course, we made a sepsis-associated acute kidney injury consensus conference from the group called Acute Disease Quality Initiative. This is the same group that has designed the rifle criteria, for example. And it is important to show that extracorporeal blood purification techniques can be used to remove pathogens, microbial toxins, inflammatory mediators, and toxic metabolites. So this is grade 1A recommendation from the ADKI group. And the other thing is that initiation of extracorporeal blood purification therapies in sepsis might be considered for immunomodulatory support in patients who meet explicit and timely clinical or biological criteria. And of course, it has to be safe and effective, and it requires objective indicators. For this reason, we have had some questions, research questions, that represent the research agenda in this field, including what is the effect on pathophysiology, in which subgroup of patient we have to identify the right subgroup of patient. Are they safe? What are the meaningful target molecules? And finally, what is the effect on other organs? I want to share with you some of the results we have achieved using hemoadsorption. In a septic patient, not only we found a reduction in interleukin-6 and other cytokines, not only we found after 6 hours and 10 hours a significant reduction in the amount of noradrenaline required to maintain a good blood pressure, but we also found in the monocytes of the patient an improvement in the capacity of expression of TNF when stimulated and improvement in the capacity of phagocytosis. And more than that, we found that the pro-apoptogenic potential of plasma in this patient is significantly reduced, showing that hemoperfusion plus CRRT provides a blood purification for substances that cause significant apoptosis in the monocytic cells and also paralyze the cells, because the improvement in phagocytosis demonstrate that. And more than that, we did a flow cytometry analysis on monocytes, and we found an improvement in the expression of HLA-DR on the surface of the substance of the cells, and also an increase in the percent of monocytes expressing HLA-DR, showing that antigen presentation can be improved. We have recommended the use in patients with COVID, and indeed we did a specific experience where, together with other investigators in the world, we found improvement in pulmonary exchanges after application of 1 or 2 sessions, such to make some expert review recommendation. And you see that in the recommendation, cytokine removal represents one of the pillars of the therapy of COVID. This was the acute disease quality initiative that we did in a Zoom modality, because of course it was in 2020. We published in Nature Review Nephrology a statement, and at the end of the story, hyperinflammation was somehow linked to the use of polymeric beads and hemoadsorption. So in the perspectives of blood purification for COVID-19, the use of sorbent seems to be a promising therapy. Patient selection was important. Starting early was quintessential. Frequent filter changes are more effective, and initiation duration of the therapy will follow clinical status of the patient. Using adequate anticoagulation is important, and we need to look for the impact on pathophysiological and patient outcomes. There are several studies now showing this use with different machines, as in this case, and this is another study from Thailand, where you can see the improvement in PaO2-FiO2 ratio after 1 or 2 sessions. This was one of our patients admitted with fever, hypotension, respiratory failure, placed on mechanical ventilation, hyperinflamed and hemodynamically unstable, treated with 3 sessions of HA380. We have this type of cartridge. After we found hemodynamic stabilization, normalization of cytokines, decrease in inflammatory parameters, and improved pulmonary exchanges until extubation. In a recent meeting with gastroenterologists and hepatologists, we also suggested adsorption as a key therapy in patients with decompensated cirrhosis in one of the advanced stage. And in this case, we are utilizing sorbent after plasma separation, where we can remove in combination bilirubin, bile acids, and inflammatory mediators. In particular, the consensus conference stressed the importance of inflammation on liver patients in this case. And you see that this can be applied using a classic Prismaflex membrane machine or other type of machines like the Omni or the multifiltrate. And there is a recent meta-analysis that shows the superiority of combining DPMAS with plasma exchange with in respect to plasma exchange alone. Cytokine adsorption has also been suggested in combination with extracorporeal membrane oxygenation, because there are several situations in which ECMO are associated with severe systemic inflammation and response. ECMO itself triggers inflammation, and there are always elevated IL-6 levels. So combining hemoadsorption with ECMO seems to be a very good option, and it has been shown reducing systemic inflammation, systemic concentration of interleukins, and better vasopressor control in this patient. This is a recent publication on the use of hemoperfusion during veno-venous ECMO, and you see the important reduction that you can notice in interleukin-6 compared to another sorbent technology or simply to controls, where in fact there was a better control of the cytokine release. How to do the combination? It is technically easy, feasible, and effective. You can use it in two ways, and depending where you connect to the ECMO therapy, you may or may not need an extra pump. There are machines like this that are specifically designed to have a function in which you can adjust and attach directly to the ECMO circuit. And this has been utilized in several different conditions. So AKI is common in patients that need ECMO, and there is high mortality. The CRT device can be connected to the ECMO, and the procedure requires, however, training. You need to have nurses that know exactly what to do. And other blood purification techniques can be done in conjunction with ECMO. Now, when you apply adsorption, you must be aware that you are removing drugs. So in the 4 hours treatment that you do in critically ill patient, you are removing drugs. And you are also removing antibiotics. So that is a very important issue, because you need to know that antibiotic delivery should be done immediately after the hemoperfusion session. We have published recently 2 papers, one in critical care, the other in intensive care medicine, that somehow summarize what I have presented today to you. And I think this would be a possibility for you to refresh and to digest maybe the many information that I gave today. What do we need today? I think we are exactly where we were 30 years ago with membranes and CRT. So we need more research. We need to identify patients' endophenotypes that are likely to benefit from hemoperfusion. We need to establish dose, frequency, and criteria for application. I just remind you that still after 40 years, the studies have not clarified when to start and when to stop CRRT. So we cannot expect to have this in 1 year for adsorption, but certainly, hopefully, we will not take us 40 years to come to this information. We need to design studies with adequate endpoints. We need to consider potential side effects and contraindication. We need to promote medical academic alliance with industry and to use homogeneous terminology. I would like to stress only one final thing concerning potential side effects. Some people, or contraindication, some people say, oh, when I have a very low platelet count, I don't want to apply this therapy. But we often see a paradox that after applying this therapy, platelet count increase. And the reason for this is the low platelet count is due to sepsis. So if you take care of sepsis, then you may have a paradox response. And the last slide is to invite you to come to Italy in June. We have a special course on AKI CRRT. This is the 41st anniversary. So we have been doing this for more than 40 years. And we have people coming from all over the world. Some people from Vietnam in the past joined, and I hope you will have the chance to visit our country, which is at least as beautiful as yours. Thank you very much.